in there. I'm joined tonight by two of our providers, both Kim Prislak, who's the Director of Clinical Services in New York, and Carla Collin, who is also a female hair loss specialist in New York City. I'm very grateful that they're here joining us today. It's always nice to have support and also have their expertise, which is a little different than mine. And so I appreciate them joining me today. Okay. Technical stuff's not my forte. So our agenda, we're going to be actually covering a fair amount this evening. I'm going to talk briefly about an overview of female hair loss and hormones in hair, and then I'm going to pass it on to both Carla and Kim to share their expertise with you. This is a very important topic. We're seeing more and more hormone-related issues with hair loss, and it's a topic that again, we're seeing more and more of and more patients coming through the door with these type of issues. But we'll be talking about an overview of female hair loss just to understand the terminology. We'll talk about the effect of hormones on hair. We'll move more specifically to PCOS and how to diagnose it and manage it. And then a brief discussion on rejuvenating treatments that do work for these patients as well. Okay. So just basically, again, I just want to let you people understand about the terminology a little bit because it may come up in some of the next discussions. There are actually 3 cycles to the hair growth cycle. There's the anagen, which is actually the growth phase. It can last up to 6 years. The catagen phase is the sort of a transition when the hair follicle starts to pull away from the root area. That can last just a few weeks. And then the telogen phase, which is the true resting phase, when the hair actually normally falls out, and then it rests for anywhere from 3 to 4 months, and then the cycle starts over. The thing that we know is that over time, and the negative effects of some of the androgens or the typical male hormones can actually shorten this cycle. So other things that can affect hair loss risk. Genetics is a big piece and probably the most common cause of hair loss in women. Stress, we all know the effects of stress on hair. The last few years have been very stressful after COVID and then the recovery. A lot of us had experienced significant shedding. Nutrition is a huge piece. We have a lot of our patients are on GLP-1 medications and other types of weight loss diets and drugs, and we're seeing the effects of that on hair if it's not monitored carefully. Any kind of illness can increase the risk of hair loss. Hormonal imbalances is the one we're going to focus on tonight. It's a big important piece of hair loss in women, how the hormones affect growth and can accelerate loss. Of course, aging is a big piece. As we age, we're more likely to experience hair loss. And then scalp and follicle health can't be underestimated. There's a lot of confusion out there. How should we keep our hair clean? How should we treat our scalp if it's itchy? All of those things play into hair loss. I'm not going to go into this in great detail, but the most common causes of hair loss are non-scarring alopecias, which is where the androgenic comes in. What it means is the follicle itself is not damaged during the process of these particular diseases and can be re-stimulated to come back. That includes the androgenic alopecia, which is the most common, the female pattern hair loss, which is most affected by hormones. Telogen effluvium's excessive shedding can also be affected by hormones, particularly after pregnancy. Traction alopecia, alopecia areata, and post-cancer hair losses are also non-scarring. Post-cancer hair loss, we do see a fair amount affected by hormones because of the large number of post-breast cancer patients we see who are continued on their hormonal post-cancer treatment hormonal therapy. I'm not going to discuss scarring alopecias today. Again, treating female hair loss, regardless of the cause, it's important to get a good, thorough evaluation, and that's what we do at Medi Tresse. A diagnosis is essential. We do a careful medical history, a good physical exam with trichoscopy. We oftentimes do blood work, which is very essential with any kind of hormonal imbalance, and both Carla and Kim will talk about that further. We rarely will need to do a biopsy, but sometimes we do, particularly in the scarring, but with androgenic and hormonally related hair loss, we generally don't need to do a biopsy, but we do check hormone levels, which are very important. The treatment plan is customized to each patient, depends on their medical history, in this particular case, what their hormones are, what's driving the hair loss. And then we monitor very carefully. Just briefly, androgenic alopecia, here's the basics, and that's what most commonly is affected with hormonal changes. Androgenic alopecia can occur without significant hormonal changes, except those that are normally occurring in life as we age, going through menopause. But PCOS is an additional imbalance of hormones, and again, we'll talk about that in a minute. But again, androgenic alopecia is the most common type. Affects up to 50% of women as we age. It increases. The key hormones are testosterone and its derivatives, which include what's called DHEA/S, the DHT. They all play a crucial role. Women naturally produce testosterone. It's when it becomes excessive or imbalanced that it can become a problem. How does that happen? Well, the DHT, which is developed in the breakdown of testosterone. It actually attacks the follicles, and in those hair follicles that are potentially genetically susceptible, it actually causes what's called miniaturization. The follicles get smaller, the hairs become smaller. That growth cycle, we talked about anagen, which is the growth cycle phase, that shortens over time, and eventually the follicle can fail. And this is just a picture that shows that the hair follicle, as it shrinks, it gets smaller and smaller, and then the hair it produces gets smaller, and then that cycle shortens. And so unfortunately, with each new hair that comes up, it can be a little bit smaller. And so the androgens can accelerate this whole process. And in time, unfortunately, some of those follicles will stop producing altogether. And again, there tends to be a genetic predisposition in certain individuals who develop androgenic, but hormonal changes, particularly in PCOS and other types of imbalances, can increase the likelihood of that happening. Estrogen, which is what we need to think about in terms of being a female hormone, can drive hair growth, but unfortunately, as it decreases when we approach menopause, it actually we can lose some of that estrogen's protective effects. This is just a quick chart here, which sort of shows what the estrogen does over our lifetimes and the testosterone. It looks like we have more testosterone than estrogen, but in fact, we don't. The estrogen is by far the stronger when in most women, we do have testosterone. But the important thing to note in this chart is that the testosterone does drop as we hit menopause, but not to the same percentage that the estrogen does. The estrogen really falls significantly. And so we lose that benefit that the estrogen provides for hair. And so the testosterone can have a stronger negative effect as we start to drop our estrogen. The thing we're not going to talk a lot about hormone replacement therapy in this particular lecture. If you're interested in that, we do have another webinar on our website which talks about that. But when women do take a hormone replacement therapy, it does help stabilize that loss that occurs during menopause, and it can help drop the testosterone levels. And again, those changing hormone ratios that occur with aging, the estradiol, which is the estrogen, drops up to 80% over a lifetime. The testosterone only drops about 25%. So that ratio is not in the best favor for hair growth. And when women have higher testosterone levels due to something like PCOS or other types of hormonal imbalances, it's even a stronger negative effect with the testosterone there. Again, this chart just talks about the estrogen's protective effect on hair. We see that during pregnancy when the estrogen levels just go sky high, and a lot of women note that their hair is thicker, it's healthier. Unfortunately, it's not permanent, and with childbirth, that oftentimes we have a bad shedding experience, but this just talks about the effects of estrogen, and we do know that the estrogen does protect hair growth. And I'm going to pass this on to Carla, who's going to talk about PCOS.
Thank you, Dr. Wendell, for that wonderful introduction. I will be talking about PCOS, its impact, and how to holistically manage it. What is PCOS? PCOS stands for Polycystic Ovary Syndrome. It is a hormonal condition that impacts approximately 6 to 20% of women during their reproductive age. That is approximately 1 in every 10 women. The term polycystic describes the presence of numerous cysts on the ovaries. A cyst is a fluid-filled sac, right? Which is very normal part of your menstrual cycle. The key here is that you have more than the average amount, which is considered to be more than 20. The name can be a bit misleading because it is important to note that not all women diagnosed with PCOS have that polycystic ovary. Okay, this is a syndrome, therefore, it's a spectrum, and everyone's symptoms look very different. Some people can have 2 symptoms, while others have 5 or 6, and some can have almost all the symptoms. Um, Diagnosis typically includes at least 2 of the following criteria. The first criteria is irregular menstrual period. That can be heavy, it can mean having less than 9 periods a year, or sometimes it can be non-existence. And this is why some women suffer from infertility because they are not ovulating. And also, this is why you have an increased risk of endometrial cancer because of that non-ovulation. The second criteria includes symptoms of elevated androgens, such as acne, hirsutism. Hirsutism is basically hair where we don't want it, hair on our face, on our chest, on our abdomen. So that is basically some of the symptoms of elevated androgen. To make matters worse, some women will experience alopecia where they're losing hair on their heads. So we have hair on our face, hair on our chest, but no hair on our heads. And that is what become very emotional and stressful for us. Okay. And the third criteria is a polycystic ovary. This can be visible on an ultrasound. And again, you don't have to necessarily have that in order to be diagnosed with PCOS. All you need is 2 of the criteria to meet diagnosis. Um, so it is important that when you do go to your provider, that they diagnose you also by ruling out some of the things that can mimic these symptoms of PCOS, such as thyroid disease, adrenal tumors, pregnancy, and congenital adrenal hyperplasia and other disease that have similar symptoms. That is like most important to rule these out before confirming a diagnosis of PCOS. PCOS goes beyond just impacting reproduction. It also has an impact on metabolism, weight, and emotional well-being. Even though it is a common occurrence, numerous cases remain undiagnosed. It is reported that a person has to typically visit 11 providers to get properly diagnosed. This is why it's important for you to seek a provider who listens, take your concerns seriously, and is willing to investigate your symptoms further to provide an accurate diagnosis and treatment plan. This is why here at Medi Tresse, we allocate an hour for our consultations. Next slide. Next slide. Hormonal imbalance is central to PCOS. Back to slide 18. Thank you. Hormonal imbalance is central to PCOS. In PCOS, the brain and ovaries stop communicating appropriately. As you know, most of us, or maybe we don't, some of us don't know, we're born with a set number of eggs. And each month we go through our menstrual cycle, a few are released based on that total amount. In some cases of PCOS, you get a release of more eggs than the average person, resulting in a dilution of the follicle stimulating hormone, right? Your FSH, which is your follicle stimulating hormone, and your LH, which is the luteinizing hormone, they have to be in a specific ratio. And when that happens and everything is well and they're in harmony, this is where we get normal ovulation. And with PCOS, because of this dilution of the FSH, then we get imbalance in the FSH and LH ratio. And so thus this causes lack of ovulation and resulting in infertility. Women with PCOS have an increased amount of androgens, also like testosterone, which is usually seen higher in males. This leads to male like features such as facial hair. We can also see the pancreas making more insulin than usual. This surplus of insulin levels causes the ovaries to create more androgens, resulting in a vicious cycle. Insulin is considered the fat storing hormone. This is why some people with PCOS are overweight, especially in the central region, right? This surplus of insulin makes it difficult for us to lose weight, even when we're eating on a calorie deficit and we're trying to exercise. It's just a little harder for those of us with PCOS to lose the weight. Okay. And obesity, as we know, is a risk factor for hypertension. Hypertension just means high blood pressure. This can, in fact, affect kidney function over time. Obesity is also a risk factor for high cholesterol, which contributes to heart disease. This is where the metabolic component of PCOS comes in. We also see a high levels of DHT, which affects the skin, hair, follicles. We'll dive into that a little bit on the later slides. These hormonal disruptions play a central role in the development and persistence of PCOS symptoms. Next slide. Hair loss caused by PCOS typically manifests as androgenic alopecia, also known as female pattern hair loss. There is a genetic component to this type of hair loss, so you can thank your parents for that. In this type of hair loss, we see the crown gradually thins as a result of this condition. And over time, you can get a wider parting line. Um, Hair loss is more diffuse and affects hair density. It's not like it's not patchy like we see in some of the autoimmune disorders like areata. The main element involved are androgens, especially DHT. Miniaturization, which is a process by which the hair follicles become smaller, shorter, thinner, happens in PCOS. And if this condition is left untreated, this can result in permanent hair loss. So this condition is usually progressive. So it is important to seek medical professional advice early on to help prevent permanent hair loss. Next slide. Hair loss in PCOS is caused by multiple biological factors. Genetic and hormonal disruptions are the driving force here, right? DHT, as we said before, which is a testosterone derivative, is one of the main hormones associated with this type of hair loss. DHT is a strong androgen. It attaches to the receptors of the hair follicle on the scalp, which results in shrinkage over time and shortens the hair growth cycle. As a result, over time, many women experience miniaturization, which is thin, weak hair. Also, we see elevated insulin levels, as we've said before, which is, prevalent in PCOS. These elevated levels promote inflammation, and consistent chronic inflammation damages the hair follicle. Right. And so this becomes a stressful environment for the person who's experiencing this hair loss. And the stress then leads to increased cortisol levels, which then exacerbate hair loss by further interfering with hormone regulation. So it's just a vicious cycle, right? So it is important to get to the root cause of the problem. This is key in providing a successful treatment plan. Next slide. Uh, as we said before, hair loss has a substantial influence in our emotional well-being, right? It's not just about physical appearance. Some of us can feel shame, diminished self-esteem, a feeling of losing control over your own body, are common experiences for women dealing with PCOS. It may even result in women withdrawing from social environments, leading to depression and anxiety. And unfortunately, the psychological effects of hair loss are frequently disregarded in medical treatment. Some women will go through this in silence, believing that the issue is just aesthetic and it's not worth mentioning. However, it is crucial to recognize the emotional component of PCOS, both as a patient and as a healthcare provider. Okay, so we do have online forums, counseling, and support groups can provide validation and guidance. Okay, and it's also to educate yourself of of what of how this of what you can do about this condition, and this will help to lessen shame and stigma. Understand this is not your fault, okay? It is important for us to address mental health, which is a component of holistic care, and this can enhance your overall quality of life. Next slide. So here we go. How do we manage these symptoms related to hair loss? So before we start, you have to tell your provider if you are planning on starting a family, because this will dictate the treatment protocol. Okay, as some of these medications can be toxic to a fetus, right? And again, managing this condition should be a holistic approach. We want some of the things that we can use are hormonal therapy, such as birth control, especially those containing progesterone, that will help regulate menstruation, and it also helps reduce androgens. Okay. Anti-androgens such as spirolactone, finasteride, dutasteride, and also a natural herb like saw palmetto suppresses DHT's influence on hair follicles. This can help slow down or stop hair loss. We have insulin sensitizers like metformin that can help improve insulin resistance and aids in restoring hormonal balance. Topical treatments such as minoxidil helps promote hair growth. Although minoxidil, we can also do it orally as well, and that also helps with regrowth. And one of the most important thing as a patient that you can do is lifestyle modifications, right? We have to eat nutritious food. We have to get exercise in, some cardio, some strength training, and try to maintain a healthy lifestyle in order for us to reduce some of that inflammation and enhance insulin function, right? Because as we know, food is medicine. Vital nutrients are vital, and they help to repair damage in the cells, right? And they also help us to strengthen our immune system. So make sure to get, your 5 to 7 servings of vegetables, incorporate supplements to help meet your nutritional needs, especially nowadays that the soil is depleted. So even when we're eating healthy, we're not getting enough nutrition. So it's important sometimes to add on supplements that can help us meet our nutritional demand. It is great if you can add some B complex, some prebiotic for gut health, because once your gut is imbalanced, then you get inflammation. And inflammation, as we just seen, can damage hair follicles. So that it's important to get your gut health in order. So eating things like kimchi, things that are full of good bacteria, that's what you want to incorporate in your diet, right? We want to incorporate more iron, vitamin D, zinc. These things are vital when attempting to restore hair, but it's also important for us to get some blood testing so that we can see what what nutrients we're deficient in order to help replenish those specific ones so that we can get the most out of our treatment, okay? Mental and emotional support via counseling and support groups helps people deal with emotional effects of hair loss. So it is important when we're managing PCOS that we manage it in a holistic approach. So we're just not giving you medication only, but we also want to make sure we address that emotional component of it. And together, this can be the most effective strategy to address both the noticeable and unseen consequences of PCOS related hair loss. The biggest takeaway here is recognizing these symptoms early and collaborating with a medical professional who is professional and attentive. Okay. And now I will pass on to Kim, who will dive into some of these topics a little bit further.
Good evening, everyone. I'm starting off with this slide, the menstrual cycle. And I think it's so important for a woman to realize every month what occurs in the body. I think when something happens monthly, we tend to not think about it. It occurs at a regular cycle. And these little small changes that can occur can affect our body, as you're going to soon see. I wanted to show this because I wanted you to see the intricacies of a menstrual cycle. Now, estrogen, obviously progesterone, as women, we all know that, but FSH and LH come from our brain. And I think that's so important to make that connection. This is our symphony. It's actually a perfect symphony. Everything is so methodical every month. And unfortunately, just in a symphony, if one instrument goes awry or one note is off, the whole symphony unfortunately changes. And so that with the menstrual cycle, you're going to see that too. And I think it's so important. It's important to track your menstrual cycle. What days, is it 28 days? Is it 26 days? Is it 32? I think it's important. Nowadays, we have apps that really will help you, but it's a very process that happens every month. And it's a beautiful process. And I want everyone to embrace it because this is something that is so important to all of us. Next slide. Now, this is what I really want to focus on is hormone testing. Hormone testing for PCOS. PCOS is a syndrome. It's a diagnosis of exclusion. And I think you really do have to do some comprehensive hormone testing to rule out other conditions. What I want to focus on is testosterone, but not necessarily testosterone alone, with DHEA and DHEAS, estradiol, and sex hormone binding globulin. First of all, I want to discuss testosterone and DHEAS. Number one thing, I always want to kind of engage you and just show you a little bit about where hormones come from. 25% of circulating hormone, testosterone comes from the ovaries. 25% comes from the adrenal gland. And then we have 50% that comes from the conversion in our skin, in the periphery, skin, muscle, and fat. Now, to evaluate testosterone, you need to know where it's coming from. So doing a testosterone and that's it is not going to tell you much. What we need to do is evaluate it by using DHEAS, which is a unique marker for the adrenal gland. And that's important because we need to know where it's coming from in order to treat. There are other etiologies here, particularly with the adrenal gland. There can be tumors, even ovarian tumors can be when you have super high testosterone levels. But women, the ovaries can make testosterone for the life of the woman. You don't need eggs to make testosterone. You need eggs to make estrogen and progesterone, but not testosterone. So this is an important concept. Now, free testosterone is what's called unbound. Okay, that's what's free to act, I call it. Now, in order to understand this, we have to look at what's called a sex hormone binding globulin. You'll see it's SHBG. Now, this is an important protein. It's a protein that's made in the liver. Now, what happens with this binding globulin? I call it like a bus. Now, hormones can get on the bus. They can grab onto this protein, but the problem is they might not get off the bus. And PCOS, you kind of want them on the bus. You want to take some of that free testosterone and bind it to sex hormone binding globulin, because then that leads you to less free to act more, testosterone. And that's what creates hirsutism, acne, hair loss. So it's important that we look at both of these and to see, usually, unfortunately, with inflammation, insulin resistance, it drives our sex hormone binding globulin down, and that makes more free testosterone available. DHES is also, it doesn't bind to this protein, so it's separate, but estradiol does. So if you're going to have two hormones that could potentially be kind of fighting for a seat on that bus. Now, estrogen plays an important role in PCOS, and this is a more newer thought. Estrogen deficiency is so important for mitochondrial function, the energy sources of our cells. What they found in PCOS is that they're missing an enzyme called aromatase. Now, aromatase takes testosterone and it converts it to estradiol. So what they're finding is an estradiol deficiency. And this is what causes overall the infertility that we see. And then overall, unfortunately, inflammation and myocardial dysfunction. We see this in menopausal patients, and you'll see there's a lot of similarities in the hormonal profiles with some PCOS and women in menopause. The next thing I'd like to look at is FSH to LH ratio. So what we see here is that LH will actually go up. Okay, so the ratio in a normal ovary is 1:1. In PCOS, it can be 1:2 or 1:3. LH goes up because you're stimulating the ovaries and you're stimulating the testosterone. If you're going to test for FSH and LH, you should do it in the early follicular stage, which is day 2 and day 3 of your cycle. I think that's very, very important. Even testing testosterone, you should test it in the morning because that's when it's the highest. So those are two really important things when you're testing hormones. Thyroid panel is very, very important. We have to look at thyroid function, which is so prevalent in PCOS, not just hypothyroid, but Hashimoto's autoimmune. You need to look at antibodies. You need to have anti-TPO, anti-thyroid peroxidase, and thyroglobulin antibodies. It's so important to get them as a baseline for a woman that has PCOS in order to follow them throughout their course. The new kid on the block is AMH, anti-Mullerian hormone. It's a fertility test, but it reflects the number of antral follicles. And these are follicles in the early stages. And AMH currently is is part of the Rotterdam criteria, which you can replace the AMH with an ultrasound. It's either an ultrasound or AMH. Now, AMH will be almost 3 to 4 times higher in a woman with PCOS because they have more immature follicles and they don't ovulate properly. So it's usually 4 times as high in a woman with PCOS. Next slide. PCOS is strongly associated with insulin resistance and metabolic syndrome. And what I really want you to do is, and I'm going to help you understand what's happening in your body. The focus here will be on insulin and fasting glucose. So when we look at reference ranges in the US for insulin, you're going to see probably a range of the cutoff to be around 25. And this is a little bit of an issue because you start to hit problems when you're around greater than 10. So this is kind of the scenario that I use when I'm trying to explain insulin resistance. So I'm looking at a door and I'm in that door and I'm trying to get that door open, but I'm weak. I'm so weak and I'm trying to push the door open. And I have to call in other people to come and help me to get this door open. And I'm pushing and finally I get the door open. And that's like glucose. Glucose is trying to get into the cell, but it can't do it. It's too weak. So then insulin comes in, but you need more insulin to get through that door, to get the insulin in. And that's the basis of what insulin resistance is. Now, once we get to an insulin of 10, you're already starting to get into that insulin resistance phase. And it's so important to be proactive, to intervene early in the early signs of insulin resistance. I think with PCOS, insulin resistance equals inflammation. So you really, when that insulin gets above that, I think you have to start looking at becoming insulin resistant. This is so important part of, and it's one of the core, parts of, PCOS and the treatment of PCOS. Comprehensive metabolic profiles. It's so important to look at body composition also here. I think there's, a concept of lean PCOS and overweight PCOS. In the lean PCOS, they hold their fat in the visceral around the organs, where obviously doing body compositions. In metabolic profiles, we look at fatty liver, which is very prominent in PCOS women. And I think this is an important part to look at everything as a whole. Lipid profiles are very important, particularly after the age of 35. I would get a more extensive profile looking at the particles, the smaller particles, and the triglycerides. Next slide. Essential nutrients are so important here, testing for them. There was a research study done in 2015. It was out of China, where they have an explosion of PCOS. They had studied thousands of women, and what they had found with women with PCOS had a dysfunctional gut microbiome. This is a dysbiosis, which leads to what we call a leaky gut. Now, leaky gut, what happens is that it's basically an impaired gut barrier function. So basically, the lining of the gut pulls apart, and where it leaves areas of where the translocation of these endotoxins in the body, creating this chronic inflammation state. So managing inflammation is so important and can mitigate some of the metabolic complications that you see. Other nutrients that I like to look for: iron, ferritin, B12, selenium. Selenium is so important for thyroid function. B12 is important for all functions in our body. Iron, important for building of RBCs and for our hair. Ferritin, more important, our hair feeds off the iron stores. And what they have found is that women with PCOS, they just don't process red meat the same either. So there's a lot of gut motility issues, absorption issues. They even have a higher incidence of IBS. So it's so important for us to really understand all of these issues that come across with nutritional testing. One thing I wanted to talk about a little bit here, and I'm just going to use vitamin D as an example, is that I like to look at reference ranges. I feel that we just don't have an understanding of where we should be. And that's a really important part of reading lab work. Reference ranges, how they come up with reference ranges is a lab will test 2,000 people, and they will have the lower end and the higher end. So basically, if you want something like vitamin D, the reference range for most labs in the US is 30 to 100. So if you're 31, you're going to be dinged as normal, and your provider will tell you you're normal. But in truth, if you have a reference range of 30 to 100, where do you want to be? You want to be on that higher end. If it's something that you want to be on that higher end. If it's something that you don't want, like liver enzymes to be up, or, other things that something that's not good for you, you want to be on that lower end. But always look at the reference ranges, even for hormones. If your testosterone, let's say, is 45, you could be normal, and that's on the higher end, and that's not where you want to be. So I think it's so important to really understand your blood work, understand the reference ranges, and if you don't know if you want it or not want it, just be right in the middle. I think that's important. The other thing that I like to look for is inflammatory markers, things like CRP, IL-6, and even ferritin can go up in inflammatory states. The other blood work that I really think is so important here is ANA, looking at autoimmunity, not just thyroid, but looking at other types like lupus, rheumatoid arthritis. I think they are common to have other developed autoimmune states with PCOS, and I think you have to be on top of all of these to prevent other issues. Next slide. Inositol. This is an important part of the treatment of PCOS. Inositol is what we call a polyol. It's a type of hydrated alcohol sugar. It has 6 carbons. It's important because it does regulate some cellular processes throughout the body. It can regulate and help improve insulin sensitivity. It can actually even support androgen reduction and actually improve hormonal equilibrium. Next slide. We have 2 types of, well, they're called stereoisomers actually, and they have very 2 distinct roles. Myo-inositol is one of the most common, most studied for PCOS. It helps regulate the ovarian health. It helps estrogen production and egg quality. What myo-inositol actually is required in aromatase, which converts testosterone to estrogen. And this is such an important role for the ovaries. DCI or D-chiroinositol is actually important to the liver, and this helps regulate insulin and glucose regulation. Now, in a normal healthy ovary, you're producing about 100 to a 1. Your PCOS, that ratio drops to 12 to 1. And what they've studied as in the blood is actually a 40 to 1 ratio. And this is considered actually the most effective ratio for women with PCOS. Next slide. How does PCOS help with hair loss? It can improve insulin sensitivity, which overall will improve inflammation. It can balance our hormones, lowering testosterone and DHT. It can help promote stronger hair and actually regulate our hormones in our cycle. Next slide. What dose? Studies have shown that myo-inositol of 4,000 milligrams or 2,000 twice a day, 100 of D-chiro. There, you can buy or purchase, a lot of the supplements are 40 to 1, which has really been proven. And you want to take it on an empty stomach at least 30 minutes prior to meals. Next slide. Next slide. Next slide. How long does it take to work and to see results? In 1 to 3 months, they have, in studies, they've showed improved energy, insulin sensitivity within 3 to 6 months, reduced shedding and hormonal symptoms, and actually some visible regrowth within 6 months. I think this is an important timeline with hair. The thing that we have to realize is that hair, it takes at least 3 months for our hair to transition. So I feel that we always have to give things time to work, allow our bodies to create an equilibrium. And I think that that is so important. In anything that we do, we have to give our bodies the time for our hair to even catch up. Some of the side effects and safety issues, mild digestive discomfort, and patients that should avoid inositol are ones that have a very low blood sugar or are on metformin or berberine, and then myo-inositol alone can be taken. Next slide. I'd like to talk about spironolactone, something that we use a lot in the practice. Originally, it was a blood pressure medication and is now widely used to treat PCOS-related hair loss, acne, and hirsutism. Spiro can block androgen receptors in the scalp, and it can affect the production of testosterone from the ovaries, and it can lower the conversion of DHT by inhibiting 5-alpha reductase. Next slide. Effective doses. 50 to 100, you can divide the doses. It can be combined with oral contraceptions. I usually give it 3 to 6 months to reduce shedding, 6 to 12 months to actually see some visible regrowth. But this does require ongoing use for maintenance. Some side effects, increased urination, electrolyte imbalances, particularly potassium, breast tenderness, menstrual cycle changes if not used with birth control, fatigue and dizziness, but they are rare. The potassium, there's been a lot of studies looking at this in younger women, at least measuring your potassium level once to twice a year. As you get older, I feel that you have to measure and monitor a little closer with that. But there are a lot of studies looking at this electrolyte imbalance. And with younger women, I feel, the medication is overall, I do use a fair amount in the practice. And again, doses change with every woman. Every woman is so different. It's an individualized kind of dosing. Starting off with 50, I think is very reasonable, but going up to 100 to 200 is of where I see a lot of the women that I treat in the practice. Next slide. Some alternatives to spironolactone is saw palmetto. It blocks the conversion of DHT. Spearmint tea, a lot of really nice research on that. Reduces testosterone, increases sex hormone binding globulin. You do need to drink 2 to 3 cups a day. Zinc lowers testosterone, supports insulin sensitivity, 15 to 30 milligrams. Nestle root actually inhibits 5-alpha reductase and also can increase your sex hormone binding globulin. I just wanted to reinforce some of what Carla had said with lifestyle interventions, particularly in the realms of nutrition. There was a huge study that came out of Israel a few years ago, and I think this is a really important study for PCOS women. It showed that a high plant-based diet and with specific timing can reduce testosterone and insulin sensitivity. It emphasized a whole unprocessed food diet, 9 cups of vegetables per day, 3 cups of fruit, beans, fiber, resistant carbs, starches, legumes were very important in this study. Timing regimen was 2/3 of daily intake in the AM, 1/3 of late lunch around 3 o'clock. There was no caloric restrictions. And this study showed that they can reduce, within 2 months, they reduced insulin resistance by 50%. They reduced testosterone by 40% and reduced inflammation by checking your 17 progesterone hydroxy and showed a normalization of the cycle. This study is beautiful. It shows us the power of lifestyle medicine. For women with PCOS, I feel that this study really did show that we have control. You can take control. And this is an important part of what we do and supporting you. I also want to just talk a little bit about sleep. I think sleep disorders in the PCOS woman is so important and so prevalent that you need to develop a consistent sleep schedule. I feel that sleep can raise, without an effective sleep, you raise your cortisol levels, and then that goes down a vicious cycle. Creating a dark environment is so important for circadian rhythm. Melatonin is affected in PCOS women. I think it's important to think about melatonin. Now, with melatonin, you want to only take a small dose, at least an hour before bedtime, maybe a 0.5 milligram, because melatonin has a circadian rhythm also. It does peak around 2 a.m. So if you take a high dose before you go to bed, it's creating a falsely high, and actually not physiologically, high. So we really just want to take us and welcome sleep. I think that's the most important part, is welcoming sleep, turning off our phones, reducing blue light, and watching the colors of the sunset. This has shown improve decrease anxiety, induce sleep. So those are small things that we can do that can have a big impact on our lives. Regular exercise is so important. I think that this caloric restriction and vigorous exercise is yesterday. Today with the PCOS patient is, resistance training, moderate exercise. I think that that is so important for any woman, particularly. Gut health, super, super important. And I just want to reinforce the mind and body. It's so critical to find out what resonates with you, whether it's meditation, guided imagery, acupuncture, progressive relaxation. I think these are so important for these women. They need support, they need emotional support, and I think you have to find what works for you. Rejuvenating treatments. Some of the therapies that we want to look at here to restore hair follicle health and promote new growth. We want to look at stimulating hair follicles. This is so important in these women with genetic hair loss, extending the growth phase, which prolongs that anagen phase. And that's a lot of what we do in hair loss today. It's all, we got to get that hair growing, get it thicker, keep it in that growth phase longer, prevent shedding. I think that's some of the most important things we can do in reducing inflammation on that scalp. Low light laser is one of my favorite treatment modalities. It stimulates the hair follicle. It prolongs the anagen phase. It extends that growth phase. It stimulates the growth transition, encouraging those telogen phase, those telogen follicles to stay in that anagen phase. Low light laser therapy, it's beautiful. It increases blood flow to the follicle by 200%, increases hair strength, decreases inflammation, accelerates wound healing, and stimulates growth factor gene expression. It's a beautiful way of rejuvenation.
PRP. PRP is platelet-rich plasma. It is a powerful treatment. It's utilizing the body's own healing factors. So when you come in, we draw your blood, we spin it on the centrifuge, and that separates the red blood cells from the platelet-rich plasma. And that is what we call liquid gold because it has platelets, it has cytokines, growth factors, all of the good things that we need in order for us to get regrowth, right? And then we will re-inject it into the specific site where you need it the most. Typically, you need 3 treatments 1 month apart, and then you'll do maintenance depending on the level of loss, either every 3 months or every 6 months. Okay. But everyone is doing PRP. Everywhere you turn, everyone has PRP. What makes us different at Medi Tresse? It is important to know that for PRP to be effective, it needs to be 5 times the concentration of blood, right? So therefore, if you go somewhere and they're only drawing up 22 cc's of blood, that's not enough for us to get that concentration. So one thing you want to know when you're getting PRP treatment is the volume of blood that is drawn, right? You want at least minimum 50 cc's. Here at Medi Tresse, we do 60 cc's so that we ensure that you're going to get an effective treatment, okay? We have 2 different ways that you can get the PRP. One is standard, where we utilize needles, but don't worry, we numb you first. So we're not barbaric. We're just not gonna inject you, without any numbing. We do a topical numbing, and then we also do injection numbing with lidocaine. And then we proceed to inject the platelet-rich plasma into those areas that you needed the most. But the new thing that we have, which I'm excited about, is the painless PRP. So there's no pain, virtually no pain. It utilizes pressure mechanism in order to infuse those growth factors into the same areas that you needed the most. So you can have your choice of standard or painless. Either way, each any of those treatments, you'll get about 90% success rate. That is what studies show for most patients. And with most type of hair loss, we can utilize PRP. Now, it depends on where you are on the course of your disease state. That is important. So if you go to a med spa, they may not understand when to utilize the PRP and when to hold off, right? Because if you're having chronic inflammation and you're at a heightened stage of inflammation, we don't want to do PRP at that moment. We want to wait until some of that inflammation is under control. So that is the difference when we're at Medi Tresse, we do medical hair loss, we do a comprehensive approach versus everyone get the same kind of treatment for every kind of hair loss.
Thank you, ladies. To finish up, I just want to present one case study of a young woman with PCOS. This patient came to us. She was 17 years old. She came with a diagnosis of PCOS. She came with some blood work from her endocrinologist. The sad part is she had already been experiencing hair loss for 5 years. This started when she was 13, 14 years old. She was very devastated by all of this. She was graduating from high school. She was doing a little bit of treatment, but not consistently. And we recommended to her parents that we do a very aggressive approach, that we start her on low-level laser therapy, start her on painless PRP, given her age. She was taking oral minoxidil, oral spironolactone. She was overweight. We did encourage diet optimization, tried to get her to work with a nutritionist. She did have insulin resistance. Supplements were recommended. She also was on oral contraceptives. It's not listed here, but we did start her on a low androgen oral contraceptives to improve her hormonal balance. And so after just 3 treatments of PRP 1 month apart and starting her on this other treatments, you can see after just 4 months, she had a very significant improvement already in her hair loss. And she was regrowing some of her hair back, which for a 17, 18-year-old girl was just an enormous improvement to see in a short time. She needs to continue with this. I do expect her to get continued improvement. As a typical 18-year-old going off to college, she dropped off on her treatments. She wasn't consistent with her medications, and we did see a little bit of regression. But once she got back on track again, understood the importance of all of this treatment, which is a lot for an 18-year-old girl to really stick to. But she was motivated and understood. And once she made the decision to go back on everything consistently, she did get her improvement back and has continued to improve. So I wanted to show this just to show that, yes, this is a disease oftentimes of young women, and it can be very devastating and really it needs an aggressive approach. The sooner the better. And treatment does make a huge difference. I want to thank Carla and Kim for their presentations. This was a great, I have to say that I've learned something here. It's always nice to learn new things. We do have a few questions, which we'll try to get to. It is getting late, but we'll try to answer a few of the questions. We'll just click here. Bear with me here. It says, if a woman with PCOS has removal of ovaries, how does that affect testosterone levels? I'm going to throw that one to Kim, but again, I think it depends on their age and what else is going on with them. Kim, do you have any words on that?
You still have testosterone coming from your adrenal gland for sure.
Mm-hmm.
You can still have some peripheral conversion too. So you're going to still have some testosterone. 50% comes from peripheral conversion from your skin, muscle, and fat.
Okay, another question, is oral minoxidil as effective as being applied directly to the scalp? The answer is yes. Studies have shown it's at least equally effective. I would argue that it might actually be a bit more effective. You get a greater, more consistent blood supply, blood level when you're taking it orally as compared to topically. And I think also people are more compliant, but not everybody's a candidate for oral. Topical does work. Somebody asked about when will the webinar be available? I think by tomorrow it should be on site. Let me see if there's a few other questions we can hit today. Can birth control help with hair loss? That's a great question. I mentioned that young woman, we put her on a low androgen birth control. not all birth control is equal. They vary significantly in what types of estrogen and progesterones they have in it. Some are good for hair and some are not as good for hair. So it's important that your provider understands that you're worried about your hair and that you want to do something, take something that tends to have low androgenic effect to it. So it can be helpful, particularly with PCOS patients, but it has to be the right formulation. Somebody asked if somebody has PCOS, does it not mean that they have insulin resistance? And again, this was a very good point that both Carla and Kim made. PCOS is a spectrum. Not everybody has every symptom of PCOS. So not every woman who has PCOS has insulin resistance, but a lot of them do. And so it's a metabolic disease, a hormonal disease. And so everybody who has PCOS or is suspected of having PCOS needs those metabolic tests to be done to make sure, because the treatment may vary depending on their level of insulin resistance and what their blood sugars and cholesterol and all of that is doing, thyroid, all of that's very important and does need to be checked. So not everybody has it, but again, it's a spectrum. Some women have only a few symptoms. Other women's, like this young girl that we met, she had virtually all of the symptoms, and it was really a difficult emotionally problem for her. Imagine an 18-year-old dealing with these things, but you don't have to have every single one of these symptoms to be diagnosed with PCOS. Last question, somebody asked if you've lost hair in a certain spot and the hair hasn't been there for a while, can it still grow back? Good question. Depends how long a while is and what the underlying cause is. If this is due to androgenic alopecia, we oftentimes can get regrowth. I'm not going to tell you that you're going to get every bit of your hair back. You know, there is a time limit. Once the hair follicles shrink up, some of them will disappear. But with non-scarring alopecias like androgenic, we oftentimes can get recovery of what sometimes looks like no hair there at all. So yes, you can get some of them back, and again, depends how long it's been gone for. This is true of men as well. You know, once the hair's been gone for a good 10 years, it's hard to pull it back, but you usually can get some regrowth even in areas that are pretty sparse. So, but the treatment needs to be multi-layered and usually comprehensive, involving more than one type of treatment plan. So again, I want to thank you all for your patience with us. This was an incredibly informative discussion. I myself have learned a few things that I wasn't aware of, so I appreciate both Carla and Kim for their input. And it will be available on our webinar, I think, within a few days. So just check back. And again, thank you all. Take care.